Hello, my name is Catherine Baldock and I'm the clinical lead for ReSPECT at the Resuscitation Council. Today I'm going to talk to you about the ReSPECT process, recommended summary plan for emergency care and treatment. I'm going to break this talk up into sections and start by explaining what the ReSPECT process is, who it is for, and how to structure the conversation. So the ReSPECT process creates individualised recommendations for a person's clinical care and treatment in an emergency situation in which they're not able to decide for themselves or communicate their wishes. It's really important to remember that it is a process that involves a conversation between a person and a healthcare professional, and what you're trying to do is you're trying to develop a shared understanding of the person's condition, their circumstances and their future outlook. And at the same time, you're trying to explore the person's preferences for their care and treatment. And then these agreed clinical recommendations are recorded on a ReSPECT form, which can be used in an emergency situation in the future. Patients feel that they have had an opportunity to be involved in aspects and elements of their care. They feel a bit empowered to be able to say what it is that they would or would not want in an emergency situation. Patients and families have also reported that they have gained an understanding of the person's condition themselves. It is easier for them to perhaps broach the subject around resuscitation, and therefore it's often much easier to have those conversations. So who is the ReSPECT process for? The ReSPECT process can be for anyone. It's relevant for adults, for paediatrics and for neonates. It's most relevant for those individuals with particular health needs that may involve a sudden deterioration in their health, people with life-limiting conditions such as advanced organ failure or cancers, for those people that may be at risk of sudden events such as epilepsy or a diabetic crisis, and for those people that are at foreseeable risk of death or of sudden cardiorespiratory arrest. In this section, I'm going to talk about those patients that lack capacity to participate in the ReSPECT process. If a clinician feels that a patient lacks capacity, they must ensure that they comply with the Mental Capacity Act and complete a mental capacity assessment, and that this is recorded not only on the ReSPECT form but also in the patient's health records. If a patient lacks capacity, then a conversation should take place with either their legal proxy, if they have one, such as a lasting power of attorney, or with a close family member. And the idea behind having this conversation is to try and establish what it is that person would have wanted. So you're not actually asking the person's relative to make a decision around any of their care or treatment or things such as the resuscitation status of the patient. But what you are trying to do is to establish whether their mother or father has ever indicated what it is they would have wanted should they found themselves in an emergency situation. And then this information can then inform the clinical recommendations that are then recorded on the ReSPECT form. So when you're having a ReSPECT conversation, you should start by talking with the person about their current clinical condition and trying to establish what they understand about what's going on with them at the moment. Try and ensure that you also understand the personal circumstances they find themselves in, and that you record whether they need any support, perhaps from carers, perhaps their husband or wife is their main carer, and any support services that they're receiving at the time. And this information is recorded in section 2 of the ReSPECT form. Once you've established this, then you should go on to ask the person about what they value, what their hopes and their fears are, and what care and treatment they would want, but perhaps also more importantly, what treatment or care they would not want. There is a scale in section 3 of the ReSPECT form, and this can be used as a visual aid to this discussion. It's really important to highlight and record this information about the person's preferences in section 3 of the form. Once you've had a discussion around this, then there's an opportunity for you to discuss the care and realistic treatments that you feel would be most appropriate for this person, taking into account the information that they have already provided and the discussions that you've already had. There should be a shared understanding about this, and this might include information such as perhaps if the patient's living in the community, whether they want to be conveyed to hospital if they become unwell, and perhaps if they do become unwell, what the reasons that they would want to be admitted to hospital, and perhaps some of the care and treatment that they may or may not receive if they were admitted. This information can be recorded in section 4. And as part of this, it's really important to discuss, agree, and record a recommendation about CPR. This can be recorded at the bottom of the page. And it may well be that this decision is that the patient is for CPR attempts recommended or the person's CPR attempts not recommended. There are huge risks if people associate ReSPECT with DNA CPR because you can have had a ReSPECT conversation and a ReSPECT form and can be for CPR. So it's really important to highlight to clinicians and particularly first responders that they must read the information that is on the ReSPECT form. It's really important to remember that a ReSPECT form is not legally binding. It is there as a guide to provide a recommendation for immediate decision making by health and care professionals who are responding to that person in an emergency. It is a fluid document which can be updated and reviewed regularly depending on the change in the person's clinical condition or their personal circumstances, or when they have a change in clinical settings. So for example, if the person was in the community and they were admitted to hospital, then the information should be reviewed and the conversation should take place with the person, assuming that they have capacity, and this should be updated and recorded on the ReSPECT form. The terminology that is used in the ReSPECT form should be appropriate to the clinical environment. So whilst a person may well be in hospital and it may well say that it is not appropriate for them to go to intensive care, perhaps the person has indicated that that's not something that they wanted, then this should all be recorded. However, if the patient is going to be discharged into the community, then it's really important that another conversation takes place with the person and the content of the form is reviewed and updated and then is appropriate to the community environment. I'm going to talk about the other supporting information that can be used with a ReSPECT form and with a conversation. If a patient has had a ReSPECT conversation, also consider whether it is appropriate for this person to have an advanced care plan, which contains much more detailed information than ReSPECT. Then that may well act as a trigger to have a ReSPECT conversation and complete a ReSPECT form. In terms of treatment escalation plans, it is highly appropriate to have a treatment escalation plan, and that again contains much more detailed and specific information, often around particular interventions. This can then work alongside the ReSPECT form. Things like the Amber Care bundle can also act as a trigger for ReSPECT, and equally the other way around. If a person is adamant that they want to refuse a particular treatment or intervention, then it's really important that they complete an advance decision for refusal for treatment, an ADRT. This is very different to the ReSPECT process. However, if somebody does have an ADRT, then it's really important that that is referenced on the ReSPECT form. There is a box which actually does ask whether there is any supporting information or any supporting documents and this is where the detail of these plans can be added. So the idea behind any of these additional documents is that they complement one another. I think my key take-home message around adoption is ensure that it is about having a conversation and that it's not just a form-filling exercise. We are listening to patients and at the same time are recording that information, but in the broader context of the clinical recommendations that are being made.